Thank you, Rachel. I'm Jonathan Soslow, a pediatric cardiologist at Vanderbilt and one of the co-directors of our DMD clinic.
I'm Abby Dierker. I'm the physical therapist in the Neuromuscular clinic at Washington University and St. Louis Children's.
I'm Niki Armstrong. I'm a genetic counselor with PPMD.
I'm Craig McDonald. I'm the director of our neuromuscular disease clinics at the University of California, Davis in Sacramento. I've been involved in natural history studies of neuromuscular diseases, including Becker muscular dystrophy, Duchenne muscular dystrophy over the years. And more recently, we've been sort of turning our attention to clinical trials in Becker muscular dystrophy patients, which has been a great experience. And I've learned a lot over the last 30 years just helping to manage patients with Becker muscular dystrophy.
All right, and then, so Craig does not have slides. We're just gonna have him talk because he's brilliant and doesn't need them. So Craig, if you wanna give us about 10 minutes, and then we will move on to Niki.
Great. Well, I've never tried this before, actually talking without slides. So this is actually kind of cool. I'm going to sort of treat this like I'm sort of seeing a patient with Becker muscular dystrophy for the first time, and sort of what's sort of the anticipatory guidance to give a patient with newly diagnosed Becker muscular dystrophy. But I think that the landscape, just to start with, I think the landscape is really changing for Becker muscular dystrophy patients. I think that for years and years, patients, I think, would come to clinic. There wasn't necessarily a lot of data that sort of pertained to their individual conditions. There was not necessarily new therapeutics that were really targeting Becker muscular dystrophy, and I think it was somewhat frustrating for patients to continue to come to neuromuscular disease clinics and MDA clinics sometimes, because it was really kind of more of just a supportive, passive approach, oftentimes to try to prevent complications. But I think the landscape has really changed now. I think there's a number of companies in the therapeutic landscape that's really put some detailed thought into Becker muscular dystrophy, some really novel therapeutics that could perhaps target Becker muscular dystrophy. We'll hear more about that in the second half in terms of the research landscape. I think one probably important aspect to perhaps start with, obviously, dystrophinopathy is a spectrum disorder from more severe dystrophinopathy, the more classic Duchenne phenotypes, to more what we used to call outlier Duchenne phenotypes, more mild phenotypes, perhaps with some genetic polymorphisms that impacted the disease severity, and then more classic Becker muscular dystrophy. And when I was starting out as a medical student, as a resident back in the old days, before we really had, I think dystrophin as a protein was discovered in 1986 when I was like a third-year medical student for the first time. And back in the old days, we weren't routinely doing muscle biopsies or genetic testing to make the diagnosis of Becker. And now, obviously, doing genetic testing and identifying an in-frame mutation really, I think, is a critical aspect of our diagnostic workup. But that being said, there's probably about 10% of all dystrophinopathy patients that don't necessarily follow the frame shift rule. So they may have a out-of-frame mutation and have a more Becker-like phenotype. There's patients that have in-frame mutations that may have more Duchenne phenotypes. So we've sort of learned, even when we're trying to develop definitions for clinical trials, we can't just make a hard and fast definition of in-frame mutation being a requirement and the be-all, end-all for clinical trials, because we'd be excluding a lot of patients that have dystrophinopathy, but and really have a Becker-like phenotype that would benefit from the from the pathogenesis. So in the old days, essentially we would look at patients. None of the patients in the old days were steroid treated, and it was really continued ambulation past the age of 16 was really a hallmark of Becker muscular dystrophy. I think that has held true for non-steroid treated patients. Then you have patients with dystrophinopathy that are treated, more severe dystrophinopathy, which are treated with steroids. The median age at loss of ambulation for a steroid-treated Duchenne population is about 13 and a half years of age. Duchenne patients, the median age at loss of ambulation, non-steroid treated is about 10 years of age. So in multiple studies, the prolongation of ambulations about 3 to 3.5 years for Duchenne patients with dystrophinopathy in terms of prolonged ambulation. So there are some Becker muscular dystrophy patients that are more severe that have been treated with steroids, and I think what has sort of emerged in our diagnostic thinking, and this actually kind of went into our current draft guidance for the FDA that a number of experts have been working on, would be essentially continued ambulation without steroids 16 years and beyond. And if you're on steroids and you're continuing to ambulate, essentially into the adult years, so ages 18 to 19 and beyond, I think is pretty much consistent with a Becker-like phenotype, and we would sort of consider that to be eligible. Patients would be eligible for a clinical trial. I think some of the companies are looking at some of the other milestones, such as continued ability to rise from the floor past the age of 10. Doesn't occur very often in Duchenne patients, but is much more common in Becker dystrophy. And that can be an earlier milestone that can give you a sense about Becker muscular dystrophy. And in terms of the natural history of Becker muscular dystrophy, Paula Clemens has done some really nice work with the Synergy network on natural history in Becker muscular dystrophy. I think there's also some really elegant work by Luca Bello from Italy, and then Eric Nix also has published some really nice natural history data in Becker muscular dystrophy. So we're getting a better sense in terms of the natural history. There's a tremendous degree of heterogeneity. Patients will lose ambulation at really quite varying times in the course of the disease. But I think one of the distinctions are these patients with Becker muscular dystrophy that have much more mild phenotypes that may just present with muscle cramping and really have very little muscle weakness that requires biomechanical compensations. And these were patients. I think we've also learned that the North Star Ambulatory Assessment is a clinical assessment that actually is very applicable to Becker muscular dystrophy patients. As many of you know, there's 17 items tested on the North Star. It's scored from 0 to 2, and so those patients actually have the top peak North Star score is a 34, but patients that generally have scores of 32 to 34 generally have very little loss of function over the course of, say, 12 months or 24 months. And so some of the trials now are beginning to not enroll those patients necessarily. It doesn't mean they wouldn't potentially benefit from a therapeutic, but in terms of a more predictable decline, when we look at patients with North Star scores at 31 or lower, and that's about 70% of the entire Becker muscular dystrophy population, they actually have a fairly predictable decline in the disease and a change in their North Star score of about 1.22 points per year, or about 2.5 points over the course of 2 years with Eric Nick's data. So that actually lines up pretty nicely with Dr. Bello's data, where they lose about 1.22 points per year, and there's much less variability in that change in North Star score in Becker than we compared to Duchenne. That actually allows us potentially to power clinical trials. First of all, these are adult patients, so there's less variability in terms of doing the North Star testing. But also just when you have less decline, there's not going to be as much variability in that North Star score. So those are some of the aspects in terms of natural history of the disease. I would say that as I approach the Becker population in my clinic, I don't typically, unless it's really a patient that's a much more severe phenotype with Becker muscular dystrophy, I typically don't treat Becker patients with steroids. The average median age at death, I think worldwide for Becker muscular dystrophy is 67 years of age. So these patients are going to live for 6 to 7 decades, and they just don't tolerate being on steroids for 6 or 7 decades in terms of the toxicity of steroid treatment. With that being said, I think people have. I know Ann Connolly has been treating Becker patients with high-dose weekend steroid regimens. People are beginning to look at even a once-a-week steroid dosing as opposed to twice a week on the high-dose weekend protocol. I certainly wouldn't typically treat a Becker patient with daily steroids, as they just don't tolerate it in terms of toxicity, in terms of bone fragility, insulin resistance, and tremendous weight gain and Cushingoid features. So I usually don't treat Becker patients with steroids, at least in my practice. There are other therapeutics that we have certainly looked at, done trials in over the years. There's trials have been conducted with Javinostat. I think there's a vamorolone trial that's about to launch or maybe enrolling. We've done a epicatechin study, which is a nutraceutical that induces mitochondrial biogenesis. We had some promising results with Becker muscular dystrophy in that population. Javinostat being an HDAC inhibitor, and then obviously with the Edgewise 5506 compound, which is the selective fast myosin inhibitor. That's really exciting. We'll hear more about some of these agents during the research component in the talk. A lot of patients, one of the first questions they ask me just in terms of day-to-day management is, what about exercise? Is there exercise I should avoid? What's too much exercise? And typically, there are some really nice studies that have looked at aerobic exercise, aerobic paradigms in Becker muscular dystrophy patients, really showing some nice improvement in terms of cardiac parameters, but also some functional benefit to doing aerobic exercise, and that usually is recumbent cycling. It could be swimming. I typically encourage my Becker patients to try to do aerobic exercise. There may be a fiber type preservation or conversion in those patients to more oxidative profiles. And then I think in terms of, we'll hear more about cardiac management, so I won't get into that. I do think that the one aspect that really gets concerning to me are these patients that get lost for long periods of time to follow up. And I've had a number of patients in the last few years that have come back to my clinic after lost follow-up that have come back with really quite florid cardiomyopathy. And Becker patients can have a cardiomyopathy which is really disproportionate to their skeletal myopathy, and we have Becker patients who actually get very symptomatic because they have more preserved motor function. They have really quite bad cardiac disease. I've had a couple Becker muscular dystrophy patients that have gone to cardiac transplantation. I think viral myocarditis can hit a Becker patient really hard and can produce cardiac insufficiency. And then there's issues just in terms of contracture prevention, which the physical therapists we'll talk about. But with that, I think I'm supposed to wrap up, and I think I was able to get through with no slides. So
Not many people could do that without slides, so that's why he's one of the greats, right? All right, so next we are going to hear from John about cardiac management. I think, do you need? Let me see. You can use this one.
I'll use this one. And it's a little bit of pressure. Rachel told me before this that this was her favorite session last year, so we'll try to live up to that. Yeah, no, I will, yeah, feel free to throw something at me too if I'm not paying attention, whatever you need to do. So I do have a couple disclosures, but nothing particularly relevant to this talk. We'll talk briefly about guidelines and then Becker muscular dystrophy progression. We'll talk a little bit about genotypes, and then we'll go through the BMD versus DMD and sort of how we manage the cardiac therapy in these patients. And I think, just like Craig said, there's a lot of variability with Becker muscular dystrophy. So I can tell you that the natural history of Duchenne muscular dystrophy is not as well understood as we need it to be. There's a lot, and there's variability with that. And there is more variability with Becker, and it's probably less well understood, which does cause some issues. And that's specifically for the cardiomyopathy progression. There are many in the field that really think of these as an artificial categorization, that this is a spectrum. And we've talked about that today already in multiple talks. And I think that is a really important thing to look at, because for us, a lot of the times it's the cardiac phenotype that's more important than the diagnosis of Becker versus Duchenne. And so that really affects what we're doing. Now, on the flip side, there are ways that I treat patients who seem to have a Becker phenotype, and those ways are different from how we treat our Duchenne patients. So what do the guidelines say? Well, there's a lot of great guidelines for neuromuscular disease and cardiomyopathy. This is one by Brian Feingold that came out in 2017, another one in 2018, and then this is recently published by Bork et al. And these are really well-written guidelines, but if you really want to pull out Becker muscular dystrophy from these guidelines, it's difficult to do. They tend to either exclude Becker entirely or just talk about it kind of as a less specific thing and just mention Becker, but not really mention what they think or what we as a field think should be done for a patient with Becker when we're screening for cardiomyopathy. So we really need to look to our understanding of the disease progression in order to treat Becker patients appropriately. And I'll go through a little bit of what we know. I should have figured that would happen. Unfortunately, a couple of my slides are not going to show through from the transition from Mac to PC, but that's okay, because the important thing is the idea and not the figure. So this is an old study from about 1995, and they looked at 134 patients with Becker, and they had really long-term follow-up, 3 to 18 years, and they had echocardiograms and EKGs. And essentially the take-home for this is that older patients are more likely to have cardiac disease. And then if you go into an older quartile, an older band in this case, that you're less likely to have someone who is completely asymptomatic, you're less likely to have someone who's got subclinical disease, and you're more likely to have someone with manifest cardiomyopathy. So it is something that seems to get worse with age. This is a more recent study from 2015, which showed a very similar thing. They looked at 30 patients with Becker and had 9 years of follow-up, and showed that on echocardiogram, the median LVF dropped from 60 to 50%, and so about a 1% drop per year, which is not that different than what we see in some of our Duchenne patients. And so it's important to sort of really get a handle on what we expect for these patients in terms of their progression. Now it's pretty active over there next door. I feel like I'm not entertaining you as well as I should. This is a look at one of the landmark studies in Duchenne out of Cincinnati, and they took a whole bunch of Duchenne patients and figured out what their progression was. And if you look at this, here in green, these are the patients without delayed enhancement or scar, and once they get scar, then you see a pretty steady decline in ventricular function. So our understanding for Duchenne is really that your cardiomyopathy starts when you start to see scar in the heart. That's when you start to have functional progression of cardiomyopathy. And we don't have quite as good data for Becker's, but I'll show you a couple studies that really make it seem like that's probably the same deal. That's probably the same thing. So this is a study from about 15 years ago looking at a small number of patients, but showed that more than 70% had scar in their heart. And this is a figure of that scar right here. This is something called late gadolinium enhancement. So we can give a medicine and then image it with cardiac MRI and see the scar. And all but one of those patients, all but one of the patients with depressed function had scar in their heart. And they also went through and looked at echo versus MRI and showed that the MRIs were really much more sensitive for detection of clinical and subclinical issues by cardiac MRI as opposed to echocardiography. Sorry. There we go. This is a more recent study in a younger cohort from Nationwide, and they looked at 33 patients. Again, about a quarter of these had scar just because they were a younger patient population, but the same story where only one patient without scar had LV dysfunction. So most of them have scar first and then get LV dysfunction. And when they looked at all the patients with scar, with delayed enhancement, there was a correlation between ventricular function and the amount of scar that they had. So they really seem to run together. See, I'm very, very Mac-centric, apparently. All right, so this is a study by Florian et al., and they looked at outcome measures. So they looked at mortality, but mostly event rates that they defined in terms of arrhythmia and other sort of cardiac event rates. And they looked at cardiac MRI to try to figure out what was the most predictive of those event rates. And as you can partially see from this figure that didn't seem to come through quite well, and I apologize for that, the LVEF less than 45% was very predictive of those event rates, and the blue line was so good that it didn't actually show up on this part of the figure. When you parse this out even more, oh look, it did show up there. Interesting. When you parse this out even more, which is also not shown here, you can actually divide by LVEF and delayed enhancement. And so that's an even better discriminator of who's going to do well and who's not going to do well with Becker. And so that the more delayed enhancement you have, and if it tends to be through the entire wall, the worse your outcomes will be, or the more likely you are to have some of those bad outcome measures that they defined ahead of time. So all of these things do fit, and they fit with what we understand from Duchenne as well. The other thing I wanted to touch base on just briefly is genotype. And for us, in general, the DMD primary mutation doesn't really seem to predict their cardiac severity. There have been some studies that have shown, oh, well, maybe this goes along with the severity, but most of those haven't been as well validated long term. And it's probably because if you don't make dystrophin that goes to the membrane, it probably doesn't matter why you don't make it, it's just not functional. Whereas with Becker, when you have a protein that's partially functional, it probably does matter what that mutation is, or it may matter what that mutation is when you're talking about deciding if you're going to be at risk of cardiomyopathy. Hopefully, I know that I hate to do genetic stuff with a genetic counselor in the room. It always makes me feel very embarrassed because I am not a geneticist. But the nice thing about this for me is when I see my Becker patients, I can look at their mutation and I might have a sense out of the gate of what their risks of cardiomyopathy are. And so this is a really nice paper, one of a few that are out there that just looked at all the different mutations. It was a small study. There were about 120 or 150 patients in this study, so not very big for a genetic study. But if you look at the data, it seems like exon 2 to 9 mutations are the highest risk, then 45 to 49 if they preserve hinge 3, and then 45 to 55 if they disrupt hinge 3. And that's kind of the sort of hierarchy for risks of cardiomyopathy. And then they further were able to separate 45 to 49, which is the middle category and probably the largest category, by whether the protein was in phase or out of phase. And so I think that it can be a very useful thing to classify these patients early on. It doesn't work all the time, and in fact, I have a patient who has relatively severe cardiomyopathy who is in what should be a low-risk category. And so it doesn't always work, and it really is important to do the screening for this. But it is something we can use. So how do we do this differently in Becker and Duchenne? And this is, I'm just going to break that down quickly and then move on to the next speaker. So for both, we tend to get yearly evaluations after diagnosis. In Duchenne, I start to see my patients about every 6 months, starting around 10 years of age, or if I see any cardiac abnormalities. For Becker, I do the same if I see any cardiac abnormalities, but I tend to delay making my patients come back every 6 months as long as I can. Because if they're doing well and their MRIs are normal, then I don't feel like I need to follow them quite as frequently. I do MRIs. I do them a little bit later in my Becker patients unless I see something that I'm concerned with. And I do my MRIs a little less frequently, and this is partially because I don't want to give them a ton of contrast over their lifetime, and so I'll space that out a little bit and try to do it every 3 years or maybe even a little less frequently. And I think there's been a lot of discussion about Duchenne patients and contrast load, and we do try to limit how much contrast we give patients, but the contrast is what we need to see the scar. And then Holter monitors, I do it a little less frequently in my Becker patients, but still try to keep an eye on them, especially if they have abnormal function. Oops, that's interesting. All right, sorry. So in terms of the cardiac therapy, I started obviously with any abnormality that we see. So delayed enhancement, LV dysfunction, abnormal strain. In Duchenne, I start prophylactic therapy around 8 to 10 years of age. And that's because I know they're all going to have cardiomyopathy. In Becker, I'm not as aggressive. If I have a patient who I think is higher risk for cardiomyopathy or who has a pretty significant skeletal muscle phenotype, I will definitely discuss starting prophylactic therapy earlier. Otherwise, I might wait till the late teenage years. But to be honest, I have a patient who played college baseball with Becker muscular dystrophy, and his heart has been normal every time I've looked. And so when he was 20 and he had a normal heart, I was like, that I can start therapy if you want it, but it might slow you down on the baseball field, and he didn't want it, and I think that made sense. I think that was an appropriate decision, and so I have a lot of patients who I have not started prophylactic therapy on. In terms of treatment variation, I really think we have to be cognizant of the cardiac phenotype and of the genotype. And then to some extent the skeletal muscle phenotype, because again, as Craig said, I have patients who should be Becker who are Duchenne phenotypically, and I have the opposite too. And so I think we really need to be careful and try to use the right therapy for that patient. Hope I didn't go too long. In conclusion, there are less data in Becker patients or in Becker muscular dystrophy. The guidelines in Becker are unfortunately less clear, and cardiac progression does seem to begin after the presence of scar, and genotype likely plays a larger role, but nothing really is perfect, and we need to continue screening in these patients. So, thank you very much for inviting me to speak. I'd like to thank our group, and yeah.
Awesome. Okay. I hate handheld mics because I talk with my hands, so apologies in advance if I do something crazy with it. When we were setting up this talk, thanks for the volume. When we were setting up this talk, we were asked to think about kind of how we approach things differently with Duchenne versus Becker. And so the first thing I did was think about what do I do with genetic counseling in general with dystrophinopathies and kind of how each of those pieces is different, potentially with Becker. And probably the biggest component of genetic counseling for dystrophinopathies is talking about the genetic variant. So we spend a lot of time with families trying to help them understand their individualized genetic variant, both kind of what does it do to the protein, how does it cause the issues that it causes, and also what do we know about it? Can we find it in any other families? Kind of what data is available about it? We also talk about testing other relatives, we talk about family planning, and we talk about therapy or clinical trial eligibility. So I'm just gonna walk through kind of each of these pieces. I cannot have a slide with genetic counseling and not show the picture of dystrophin. It would be just wrong, I think. But as everyone else has already said, Becker and Duchenne are a spectrum, they're dystrophinopathies. I love Annemiek's analogy with the carabiner, but for me, it's a shock absorber. I think of a shock absorber. The dystrophin protein is a shock absorber to help stabilize the muscle cell membrane. The Duchenne gene we've talked a huge amount about already, but it has 79 exons. Just as a reminder, each one of the exons codes for how to make the protein, and the introns are the sequences in between that do not code for protein. I love this picture because it shows how all the exons fit together. They look like this beautiful puzzle when all of them are present, and every piece just makes this train that fits. It is the largest gene in the human body, which if you guys were in the main session earlier, we have heard can cause, it causes some complications when thinking about treatment. Now, when we're thinking about genetic variants in dystrophinopathies, we know that there can be differences from Becker to Duchenne, but the most common genetic cause of both Duchenne and Becker are large deletions. And what we mean when we say that, a deletion is a missing section of the gene, and large means it's at least 1 exon. So that's the most common cause of both Duchenne and Becker. The next most common cause are differences within the actual code of the gene, so within the sequence itself. Those kind of variants can be a little bit different from Duchenne versus Becker. And Becker, it's a little more common that we would see a switch out for the type of chemical, whereas in Duchenne, we more often will see a stop or a nonsense. And then we can see duplications where there's whole extra sections of at least 1 exon in both Duchenne and Becker. This is my favorite, like, back to genetics slide. So this is just making the gene into a sentence. So at the top, we have our full sentence with all the parts of the gene there, but you can see kind of how each type of genetic change affects the gene itself. So with a deletion, we're missing a word. With a duplication, we get an extra copy of the word. With a nonsense, we're inserting a stop. So that's like a period in the sentence, and we're making it stop. A missense is where we're switching out just 1 chemical. So it's just a little teeny tiny change, but sometimes it can have a big impact. And an insertion is when we're adding or inserting a couple of chemicals. So we've already heard a lot about reading frame today. So raise your hand if you feel like you have a good understanding of the reading frame rule. There's some hands up, okay. There's also some hands not up, so I'm gonna do these slides. So the reading frame rule is how we understand why some deletions cause Duchenne and some deletions cause Becker. And essentially what we've got here with our sentence on the right is, left, is all the words making up the gene, and you can see all the pieces fit together. We get a protein. That protein tells that, it makes the dystrophin protein, it works well, does what it's supposed to. When we have an out-of-frame deletion, so here we're missing a word, the remaining pieces don't fit together. Because those pieces don't fit together, no protein is made. If no protein is made, then we typically get Duchenne. When we have an in-frame deletion, you can see the remaining pieces still fit together. And because those pieces still fit together, we get a protein. And because some protein is made, most often we get Becker. One of the most common questions we get from families is to try to predict what it's going to look like for their loved one or for themselves. And so in general, out of frame means no dystrophin and Duchenne. In frame means some dystrophin, probably Becker. But as everyone has already mentioned, the reading frame rule is not perfect. Most of the time, you'll hear somewhere between 70 to 90% of the time it's accurate. It's more accurate with deletions than it is with duplications. Now, one of the biggest complications, I think, with Becker is what you've kind of already heard. Becker is more rare. We have less data about it. Because of that, Becker variants are more rare. So one of the things we do at PPMD is when families have questions about the variants, we actually go and look in the Duchenne registry because we collect genetic information and information about how people are doing, and so we can take a look. But for a lot of Becker variants, we don't have anyone else that has that same variant because the variants are more rare. So we have less data that we can provide there. This is my plug for joining the registry, though, because the more people who provide data, the more we'll have going forward. The other piece that we see more often in Becker is where the genetic change is found incidentally. And what I mean by that is the person, when they had the testing, nobody was looking for Duchenne or Becker, and they found it. Like, maybe they found it because a kid was in the hospital after a stomach illness, and they did some liver enzymes, and things stayed elevated, and so then they did the genetic testing. But oftentimes it's not because there were specific symptoms. It was because some random reason the testing was done and it was found. We see that a lot more often. We're also seeing a lot more Becker variants found in women who are undergoing what's called expanded carrier screening. They're pregnant or considering pregnancy, and they do a genetic test to see if they're a carrier of anything. And we're finding a lot more variants that are associated with Becker that way. And as everyone has already said, the variants with Becker can be associated with a much broader range of symptoms. In genetic counseling, we talk a lot about testing family members. We know that it is far more common for a mom of a person with Becker to be a carrier. With Duchenne, it's about 60% of the time, but with Becker, about 90% of moms are carriers. We always recommend testing for all mothers of children with Becker. We also recommend testing for siblings, all of them, even if mom is not a carrier. We got a couple of families where both, multiple siblings have it. And the other thing that's different about Becker is that we will oftentimes recommend testing other male relatives in the family. With Duchenne, we don't do that as much because we would expect symptoms in the adult male to already be there. But we have a couple of families now where we've had a child diagnosed, and then it turns out grandpa has the same genetic variant, but just has a much milder set of symptoms. So it is often, if we find a variant that we don't know very well, oftentimes we are recommending testing older brothers, adult, uncles, grandfathers, lots of other people in the family. This is our plug for our free genetic testing program. Hopefully you're all well aware of it, but it's available for any male or any female for carrier testing, and really the criteria are very loose. You just have to live in the US or Canada and need to have genetic testing. We also talk about family planning with any family that's interested. The family planning discussions are actually very similar between Duchenne and Becker. I would say that the difference is that there are more men with Becker who have families. And in those cases, we talk about X-linked inheritance from their perspective in that all daughters will be carriers and no sons will have the condition. But otherwise, as far as options to the pregnancy, they're exactly the same with Duchenne or Becker. And if that's something anyone's interested in talking about, you can always reach out to the genetic counselors at PPMD to discuss. And then lastly, one of the things that families have questions for us about are therapy and clinical trial eligibility. And this is where there's a pretty big difference between Duchenne and Becker. Unlike with Duchenne, where there are therapies that are based on the specific genetic change, there are not any Becker therapies that are based on the genetic change. It's important to understand that those therapies in Duchenne, the point is to produce some dystrophin, and most people with Becker are already producing some dystrophin, so it's a different approach. And in general, clinical trial eligibility in Becker has really been primarily based on function and health because with the muscles at least, there's a really broad range of how it's affected with any one particular genetic variant. This last is just us genetic counselors here at PPMD, so we're always available to answer any questions. We're all here at the conference, and we'll also be at the booth at the vendor fair. So.
Thank you, Niki. All right, next up we've got Abby Dierker from St. Louis Children's, who's going to talk to us about physical therapy, and then when she's done, we'll have a few minutes for Q&A before we change gears over to research.
There we go. Okay. I'm Abby, the physical therapist at Washington University in St. Louis, and so I'm just going to talk today a little bit about physical therapy considerations in Becker muscular dystrophy, and more so how to kind of approach the big questions, like what sort of exercise should I be doing, what sort of stretching should I be doing, and a little plug at the end about kind of just prepping ahead of time with equipment. So, to start, there's no one size fits all for any of these guys, but with Becker, there is a lot of variability. So in clinic, I tend to see patients, one-on-one, and we talk specifically about where they're at, what they can do, and what they want to do. So, we want to look at it from that perspective and how we approach exercise and pain management and equipment needs. So no matter who you are, the CDC recommends 150 minutes of moderate intensity exercise a week. Okay, so what does moderate intensity mean? What does that look like? And does that apply to Becker? Technically, yes, that still applies. Your muscles are still muscles. Your heart still needs, a little bit of activity to stay healthy. And so we want you to do those sorts of things, but we have to do it a little more carefully. So, I think Craig had mentioned probably the same study that I had in here that, 30 to 45 minutes of mild to moderate cardiovascular exercise is healthy. It's good, but we want to just make sure that we're not pushing too far. So the main thing with that is not pushing to fatigue or pain. And when I talk to patients about pushing to fatigue, what that looks like is you're not able to go home at the end of the day and do your normal activities. You're struggling to get up out of a chair. If that's something you normally have a little bit of a challenge with, now it's gotten much more difficult. Or if you get to the next day and you're still really fatigued, those are the things we want to say, maybe pull it back a little bit. Either go a little slower with the activities you're doing, whether it's walking or recumbent biking, swimming, or maybe shorten the time a little bit, or take a break in the middle. So for mild to moderate, they say you should be able to hold a conversation, but not sing or stop talking, or stop talking to catch your breath. So as long as you're not singing, you shouldn't be able to sing, but you should be able to still talk while you're exercising. And another important fact is don't shoot for that 150 minutes. If you want to start exercising, start small and see how your body reacts to it. You don't want to just jump in and start doing something because you most likely will feel some sort of fatigue, and we don't want you to get confused with that or overdo it and really set yourself back. And I'll talk a little bit more about limitations in a little bit. Another thing is strengthening recommendations. So typically we hear, with neuromuscular disorders in general is that, we shouldn't be strengthening. And I think that that's a little bit of a misconception. No, we don't expect you to make strength gains by strengthening exercises, but there are some strengthening exercises that are a little more tolerable and can be helpful. So recent study showed that mild to moderate, again, isometric exercise can help can be beneficial without causing harm. And so the difference of isometric versus eccentric or concentric exercises, most people don't think of strengthening an exercise in these terms, but like a concentric exercise would be me doing a bicep curl. I'm bringing that weight up, my bones are moving, my muscles are moving my bones. Eccentric would be lowering that down, and isometric would just be sort of like pushing together. So you're activating the muscles without moving the joints through their range of motion. And I think a lot of why that's more beneficial, whereas eccentric exercises are a little more harmful, it's kind of like what Niki said about the dystrophin being the shock absorber. And so as those muscles go through all that movement, it puts more stress on the joint. And if you have any more questions on what type of exercises that would look like, we can answer that in the questions. And then another one is we want to avoid working muscles that have less than 3 out of 5 strength, and it kind of all goes along in the same principle. So if you can't raise your arm overhead, we don't want you to continue to try and work to that because those muscles are already working at their hardest. They're already doing the best that they can. So if we try to do more exercises there, it's just going to wipe them out even more. So those would be places that range of motion and stretching would be great, but not necessarily actively trying to do exercises. On to stretching and range of motion. I'm sure if you have been to any neuromuscular care center clinic, you have heard to stretch your ankles or your son's ankles. And I will tell you that every single time too, and there's a lot of things that are important. These are my guidelines. I think every physical therapist is a little different. I say 3 times per side, 30 seconds each time you stretch. A runner's stretch is a great stretch if you are ambulatory and able to walk, and then if you need help with that stretch, just having someone stretch your ankle, because the calves tend to be the most, the first to kind of really get tight and form contractures, but this applies to the whole body. Shoulders, knees, hips, a lot of times if you sit more frequently, your hips are gonna get tighter, your knees are gonna get tighter. So stretching daily is good for all of us, especially for our Becker cohort. Okay. So what to avoid? I talked a little bit about not pushing to fatigue and not pushing to pain. And pain can look a little different depending on what you're doing. If you have weakness in your shoulders and you are trying to do range of motion and maybe your shoulders are unstable, you're gonna feel some discomfort there. And we don't want you to push through that because that shoulder is already loose. Same thing with hips. If you're already a little uncomfortable, we don't want you to push through that. Now, if it's just a stretching, kind of a tight pain, I wouldn't call that pain, we'd call that discomfort, and I would encourage you to keep going within reason. And then with the fatigue, I do want to touch on one other thing is we really want you to pay attention to your fatigue, because if you get to a point where you're so tired that you're not able to walk as well or transfer as well, you're going to put yourself at a higher risk of falls and injury. And from a PT perspective, that is what I care most about as far as prevention. And if we can keep you from falling, that's our goal. Okay, lastly, I think, home safety and setup. Starting to think ahead, there are progressive parts of this diagnosis that we may not be able to prepare for, but other parts we will. So like I said, we want to avoid falls. So if that means starting to trial using a cane a little bit earlier, or a walking stick, which I often recommend because it's a little easier to use than a cane, even if you don't need to use it all the time, just kind of getting used to it and used to that idea so that we can encourage it sooner. And then if you need a scooter, just get the scooter. Don't put it off and put it off and put it off, because if you're tired and we can prevent falls because we keep you from pushing yourself too far, that's our goal, right? And it's not that we're saying, oh, you're progressing to this level, we need you to switch to this now. It's saying, we want you to be active and independent and involved. Let's do this so that you can do that safer. And then if you can find a PT or an OT that you're comfortable with locally, who can work with you on a year-to-year basis, like if you don't have someone in your clinic, that can be invaluable because they can also see these changes over time and help make recommendations ahead of time, help you stay ahead of the curve. Yep, that was it. Cool. All right.
Thank you, Abby. That was wonderful. You're not going to turn it off. You're going to take it with you. All right. So we've got a few minutes for Q&A before we switch gears to research. So what questions do you have for our panelists? Just shoot your hand up. Erica can run the mic to you. Looks like we've got a question from Mindy.
Hi, thanks. I'm Mindy Cameron, and I just have a question. If we do get on the RUSP with newborn screening, do you anticipate seeing a lot more Becker?
That's a great question. So the newborn screening, the way it's set up now, is a CK-MM, which is a form of CK, the muscle-specific form of CK, followed by genetic testing. I think that we will, not everyone with Becker is going to be identified by newborn screening. If someone does not have muscle damage at birth, their CK-MM would not be elevated, and so they would not be picked up by newborn screening. Our theory is that folks that are on the more severe end of the Becker spectrum will most likely be identified by newborn screening, and we have seen that. Our pilot in New York State did identify one child with Becker, and some of the other preliminary studies that were done using the same assay did find someone with Becker, but we fully expect to miss a lot of folks who have Becker who have that would be likely to have more of an adult onset form of Becker. We will likely miss those through newborn screening.
Okay, so I'm going to ask a question and flip that kind of on its head. So I think my question's probably for Craig, but anybody feel free to chime in. So what about those patients who are asymptomatic into adulthood and perhaps they're identified because of some sort of incidental laboratory level that's picked up, or their daughter is diagnosed as a carrier during genetic testing in pregnancy? At what point with someone like that would you consider them to have Becker, or just say, this is an incidental finding? How do you follow those types of folks? There's a lot of ambiguity, I feel like, and probably some confusion.
Yeah, I think, oftentimes you have patients that may just have cramps, essentially, and, no identifiable weakness whatsoever. I don't think we have enough natural history to really know what happens to those patients over, say, 10 years of follow-up. I would say, if you've got a dystrophin mutation and your only manifestation is cramps, maybe a little bit of hyperCKemia, I still think it warrants you having a rigorous cardiac follow-up long-term. I think periodically a neurologist to sort of touch base with those patients. I do think that, some of the therapeutics, for instance, the selective fast myosin inhibitors, could actually have symptomatic benefit for those patients. And pain manifestations is a big component of Becker muscular dystrophy. With certain diagnoses with neuromuscular disease, fascioscapulohumeral muscular dystrophy, Becker muscular dystrophy, those patients oftentimes get musculoskeletal pain, and I think that you might be able to actually have a positive impact on pain with some of these therapeutic interventions, such as Edge 5506. Even the Edge 5506, the ARCH study that's been done has shown some improvement in musculoskeletal pain as one of the outcome measures. So I think we have to still think about treating pain in these patients with Becker muscular dystrophy.
That was going to be my next question, so perfect.
I'll ask you a question, Craig. So what about patients who are non-ambulatory? So like Edgewise is in trials. Is that something that you can treat with now, or is that still in trials?
Yeah, it's still in trials.
Okay, because
And they're not really doing non-ambulatory
Yeah.
trials at this point in time. I mean, presumably with a FDA label, it might be a broad label, and presumably if something got FDA approved, it might be a broader label and allow us to potentially treat some non-ambulatory patients. Obviously, you'd be probably trying to preserve upper limb function in some of those patients, but yeah, that's a good question.
And we're going to hear from Edgewise here in a few minutes too, so I think it'll be great to ask Edgewise those questions. I think we have a question in the back.
I just had a comment. I just wanted to, I'm Laura Case, I'm a PT also from Duke, and I wanted to back up what Craig was saying, because what we've been seeing in the Pompe world, which is another neuromuscular thing, with newborn screening, is that people that get identified with supposedly late onset, where you don't expect that they would have onset of symptoms until they're a lot older, but actually with newborn screening, we've been evaluating the infants, and you actually can see symptoms way before, if you scrutinize things, you can see symptoms way before you would have otherwise. And again, as you were saying, you can do a lot more preventative care if you identify people early, I think.
That's really great. Thanks, Laura. What other questions? We've got one right here.
As far as disease progression, what is the opinion that you can expect, for instance, two cousins whose grandfather had it to follow that progression? You knew that was coming. Or is it more of you're looking at their CK levels? Say one has CK levels through the roof and one not so much. What do you think has the biggest impact on disease progression, and what can we kind of look at to kind of predict the future, or try as best we can to prepare?
Do you want to? I don't care. Yeah, I have anecdotal.
Yeah, I always tell families that, one, we can never predict the future. We would be very rich if we could do that. But I always tell families that when we're thinking about that, there's a lot of pieces to consider, right? The genetic change is one piece. It's, a section of the puzzle that's important, but it doesn't tell us everything. Family history is another piece. But with Becker, it's less predictive than what we see with Duchenne. Another piece is, the CK gives us a little bit of information, but as already been said, the CK can be all over the place depending on what happened before the CK. So there's a lot of different pieces, but nothing all together.
Yeah, I think you can have variability or heterogeneity even within a family of patients with identical mutations can sometimes look somewhat different. That's probably could well be due to genetic polymorphisms, similar to what we see with Duchenne muscular dystrophy. Could produce a lot of variability. I think there can be variability in the cardiac manifestations of the disease. I had two teenage brothers. One was actually 19 or 20. The other was 15, and the 15-year-old developed acute fulminant cardiomyopathy and died while on the transplant list. And the older brother, his heart was fine. Is that due to some sort of viral myocarditis on top of? And who knows? But we see these instances of even variability within a family.
Just anecdotally, my brother and my cousin both have Becker, and my brother, I think, lost his ambulation around the age of 21 to 23, and my cousin, who is 25, still is walking. So there's definitely variability within family.
We have so much to learn, isn't that right?
Another question back here.
I have a question, actually, just so I understand for the geneticist. So I think it's so important to get it on the RUSP, to get Duchenne on the RUSP. But I was, and shows that I'm out of the loop. I'm surprised that CK testing is going to be done first, and then whether or not you do genetic testing will hinge on the CK. Because I thought CK at around the time of birth was variable.
CK is variable at the time of birth, but it tends to be really, really elevated in Duchenne. It's actually probably most accurate about 2 weeks after birth, but that's just not the way newborn screening is done in the US. There are some states that do a 2-screen process. Actually, Texas is one of them. So that second screen is going to be incredibly effective at diagnosis. There are going to be some families that have to do a repeat test, probably because it's elevated just because of difficult labor and delivery. So. Oh, we're going to miss folks with Becker because not everyone with Becker has an elevated CK until later in life. It's just going to be the way that, I think eventually newborn screening is all going to be genetic, but we're not there yet. So that's, down the line.
Definitely some limitations. Tally?
Hi, just wanted to ask, with the vamorolone approval that is coming up, would it change the recommendation about steroids for Becker?
I almost want to defer that question and have Craig answer it after we've heard Paula's talk on vamorolone. Would you guys be okay with that? Because I think that data is really helpful. I don't know if you want to add a couple of 2 cents in right now.
Yeah, I mean, first of all, I think it's going to be, it may well be challenging to, I think you're going to have to finesse it to get a Becker patient treated with vamorolone. It's not going to be an inexpensive drug, and if you've got a defined diagnosis of Duchenne muscular dystrophy, my guess is the ultimate FDA indication is probably not going to be for dystrophinopathy. It's probably going to be for Duchenne muscular dystrophy. But that being said, I'm sure there's ways in which physicians may be able to sort of finesse a dystrophinopathy characterization in terms of the documentation and get a Becker patient on. I know that Paula, you all are, I think, embarking on Becker trials. So, yeah.
That also might be a place for us as the patient advocacy groups to try and leverage that as we have maybe data comes out from those type of studies of pushing on regulators to try and get broader labels faster and just get access to patients. So definitely things for us to keep in mind too.
Access is, of course, one thing, but is what you said about taking steroids for so long time. So would it be changed based on, the way vamorolone was developed, or would it be the same thing?
Well, I think I would have less reticence about a patient being on vamorolone for a long period of time. It's very bone sparing. You don't really get the bone fragility, bone health issues with vamorolone. I think that the big issue would just be weight management and adequate dosing so that the patient didn't gain excessive weight if you had a Becker patient treated with vamorolone for a long period of time.
And Tally, I think Paula is probably going to answer a lot of your questions too as she talks a little bit about it. I would say we have time for one more question before we shift gears. Any other questions? All right, right here.
I have one more. My son's cardiologist didn't recommend a cardiac MRI yet. I'm very concerned about the cardiac implications based on family history. So he's 10. And now they did also start him on blood pressure medication. So I guess that's my question. At what point should I kind of push them for it? Because he doesn't go to a certified center. I forget how you call them.
I mean, that's a great question, and I think that, again, without the guidelines, we all sort of have a little bit different methods of how we're following patients and what we're doing. And I don't know if he was hypertensive and that's why they started the lisinopril, if it was just prophylactic. Again, it is something we do, like I started in 8 to 10-year-olds and Duchenne patients, and I'm a little less aggressive in my Becker patients just because there's so much variability, like I said. I would recommend an MRI. I don't think you're behind the 8 ball at 10. I mean, I do it in that 10 to 12 range. I think you have plenty of time to get it done. And if things are looking good, then I think you're right in there. And I think it's just fine to wait a little bit. If you get to 12 and he's like, I don't want to do it, then you can always say, hey, what about a cardiac MRI? I've heard that those can be helpful. And I think that's the way to go. But I don't think you're behind the 8 ball. And in fact, you're probably ahead of a lot of patients if you're on lisinopril or another blood pressure medicine. So.
Awesome. Well, thank you to our wonderful panelists. You were all absolutely wonderful, and I think gave us a really nice baseline as we now start to talk a little bit about research. So can my research panelists come on up?